Hi, everyone, and welcome to today's webinar. We are super excited to have you join us for today's topic, which is PDPM retooling before COVID and after COVID, or BC and AC. My name is Ken Bell. I'm the Vice President of Marketing for Simple LTC. We're happy to partner once again for today's webinar with QRM, or Quality Rehab Management. They always do such a great job. And they've worked with us to put together this free educational opportunity for you today. So again, welcome. We're so happy to have you. So back in the BC world, or before COVID, as Susan calls it, we only had a few months to get accustomed to PDPM and what its impact would be on patient care. And then COVID happened and disrupted everything. So now we're in the AC world, or after COVID. And now it's time to take stock and refocus on PDPM collaboration and execution and how it's impacting our organization. So that's what we're here for today. So Susan's going to take us through several of the most critical elements of PDPM, both BC and AC, that are affecting your clinical and your operational outcomes. And she's also going to cover several best practices and recommendations on how you can take control of that process to improve your outcomes. So before we dive in, just a couple of quick housekeeping items. So questions and answers, you can feel free to ask a question at any time during the session today. And to do that, there is a Q&A button on your webinar panel. Just click that and type your question in at any time. And then we'll collect those questions as they come in, and then Susan will cover as many as possible in our Q&A section at the end of the session today. And then also regarding handouts, if you don't have those already, people always ask, how can I get the handouts? So Jessica's with us today, and Jessica's going to put a link in the chat box, and I think it's probably already there. So you can just click that link, download them as a PDF file, and you can print that out or view it on your screen, however you'd like to do that. But again, the handouts will be in the chat box. So now I'd like to go ahead and introduce our speaker. We're happy again to have with us Susan Krall. She is the Chief Strategy Officer with QRM. Susan is a physical therapist with more than 30 years of multi-state post-acute rehab management experience. And her client base at QRM includes both for-profit and nonprofit SNFs and CCRC campuses all across the US. And Susan's primary focus with QRM is partnering with her clients to identify and implement strategies that drive enhanced outcomes and patient satisfaction in our rapidly changing PDPM world. So with that, welcome again, everyone. And so happy to have Susan here. So Susan, I'm going to turn it over to you to get us started.
Oh, thank you, Ken. I appreciate the opportunity to be here. And really, first, I just want to thank everybody for their time today and for everything that you've been through with COVID. It's just mind-boggling, the world that we ended up living in suddenly over the past year. What you've been through and your commitment to your patient care is just admirable. And so I'm hopeful that in speaking of COVID, in the before COVID and after COVID world, I'm so hopeful that COVID is now something that we can look in our rearview mirror and think of it as, time to move forward and to have COVID behind us. So I'm super excited to be here. I appreciate you all so much for everything that you do, and I hope that I can provide some insight, some value. I'm going to be sharing information that I have gathered from our wonderful clients. One of our esteemed colleagues, Kelly Roberts, is actually the one that coined the term BCAC. We were having a lively conversation, and she shared that, it's time. It's time. We're ready. We've been through, where and back, and we can do this. We can regroup and be better than we've ever been before. And so I'm going to try to do it justice to speak to BCAC and the world in which we are in right now. I also want to thank our creative support that I have in Amy Gerlach. She's always making us look more fun and professional, and clinical content and information I'm sharing, I've gathered through our clinical reimbursement and medical review team. Ashley Duggan, Megan Ussery are tirelessly supporting our clients and auditing and looking for opportunities to enhance everyone's outcomes. As Ken mentioned before, that's our mission. So I want to just dive in again with our objectives to make sure that, now is the time to really regroup on our PDPM knowledge base, look at the trends, a little bit of what we're seeing out there and the thousands and thousands of audits we're doing every month, can look again at strategies for optimal capture and retention of the reimbursement. We know that medical review is heating up, and actually the next webinar we're going to be doing is going to be speaking to medical review and what trends we're seeing there, and that'll be later in June. We're also doing something for ANAC with that. But then we're gonna go over the 5 key missed opportunities, which actually turned into about 25, but I'll try to keep it brief. Lessons learned, there's so many out there. And then really, just want to make sure that we can review again the understanding of not only the clinical impact of PDPM, but the impact of our documentation on our financial well-being. So we're going to move forward with our next slide and ask a little poll question, I believe. Ken? So the first poll question is: an interdisciplinary meeting taking place prior to the ARD date to review each patient's PDPM component capture. Curious to see what your thoughts are there. Yes, no, or not sure. We'll give everybody a second to answer that. Ken?
Yeah, we'll leave this up just for a few more seconds so we can get a good quorum of our attendees today. We'll give you about 10 more seconds. So yes, no, or not sure on those meetings.
Thank you.
Okay. Looks like we've got over 2/3 of our attendees, which is several hundred folks, have voted. So I'm going to end that poll and then we will share those results. So what do you think, Susan?
Okay, good. I'm thrilled that I got 59% saying yes. Thrilled. I don't know how to do it any other way. We've got, and my whole soapbox here is that we are so fortunate to be in the same setting now, hopefully after COVID, where we can regroup and get our team members back together, where we can really get back to the basics of communication and collaboration around our patients to identify all of the needs that they present with in those first few days in our building, so that we can develop an appropriate plan of care, and that we can set appropriate goals, and that we can get paid for the patients that we are accepting into our care according to the PDPM rules. So thank you for that. I applaud you all that have been able to stick to it and are having those meetings. So let's keep going, and we'll see what your thoughts are as we move forward here. But so, before COVID, I think we were very consumed with our preparation with this massive change in reimbursement, right? It was the biggest change in Medicare that we've had in 20 years. It was massive. We were educating. We were practicing, we were simulating IDT meetings and collaboration, putting all of our clinical eyes on those patients and talking about them and making sure we understood the PDPM questions that were being asked, those 161 items on the MDS that not only drove identification of patient need, but also drove reimbursement. And really, the financial forecasting, we spent a lot of time looking at the impact of the reimbursement. We went through that whole transitional IPA process, and that was in October of 2019. That was not a reality check on what that reimbursement was. So then we looked at November, December. By the time we started looking at what was happening to us, we're in January, February, and then March, our whole world became consumed with COVID. You had no choice but to commit every day. I honestly have no idea how you did it. 24/7, making sure that infection control was better than it had ever been in our imaginable lives. And then just everything had to be reported, and you all know what you lived through. And our teams were just completely disrupted. We couldn't get people together. We had team members that were out. We had temporary staff coming in that had never probably heard of PDPM. So those of you that are, remained committed and were able to continue your processes and your communication, it really was apparent in the data that we've seen where we had those systems still in place and where we saw the disruption. We look at trends every single month for our client base, and it is very obvious when communication is disrupted. So everybody knows what you went through during COVID. I'm going to try to leave that in the past and move forward to our world of after COVID. And now we're looking at, regrouping. And I just started hearing, when Kelly and I were talking, this was a few weeks ago, and it was just, she said, we're ready. We're ready. We're ready to get back together. We're excited. We can do anything. After what we've been through, we can do anything. And then as we had our routine client meetings, we just consistently kept hearing, everything fell apart. We have new people, we have people that never heard of PDPM before. We've got to regroup. Let's start over. Let's get the basics again. So we've been pulling up out of the archives a lot of our basic PDPM training that we did in the beginning, because we found we have a lot of PDPM knowledge gaps. And we have a lot of people that are in our industry that kind of have things have kind of morphed. We need to get back to reality and really look at the rules, look at the RAI manual, look at what really drives reimbursement. And what we believe to be true, I believe, is that it is a patient-driven payment model. We have seen those, extensive services being captured for COVID and special care high with some of the complications. But now that those extensive services are leaving, we're seeing a lot of patients dropping into these lower categories. We need to make sure our nursing team, our team members, our physicians, our practitioners all know what we need to capture in PDPM. So we have some knowledge gaps to fill. We hope to give you some tools for that. And then in February 2021, there was an article that did state there was an 83% drop in number of new cases. So I am continuing to see that. I had an entire chain that said for the first time, they had multiple buildings. For the first time, they were able to say they were COVID free. I believe one of the states actually has reported now they've been COVID free. So we're going to move forward and retool our PDPM approach. So let's go to the next slide and see what we've got coming up next. Looking for what worked in the few months that we were getting ready, what really did set us up for success, what has proven successful in identifying patient needs and identifying the reimbursement opportunities has really been that communication. There's nothing that beats it. We again have our patient right there in the building with us, surrounded by nursing, therapy, PT, OT, speech, all with different clinical eyes. We've got, our nursing staff is so impressive. Our nurse practitioners and our physicians, our social services. We've got clinical eyes that can be focused on the needs of the patient. If we can just get it from them into the documentation and into our communication, into the MDS, onto the claim, you will be paid for who you are taking care of. But it's really difficult. This is a difficult system. So first of all, what is the right ARD? What is that first assessment? That first 7-day window is crucial. It drives your reimbursement for the entire stay unless you choose an optional assessment. What assessment reference date is selected will absolutely make a significant impact on your reimbursement, should there have been something in the hospital that you could claim. And the reason why all of these things are so important to your reimbursement is that CMS is driving us to look at situational problems that these patients present with, conditions, comorbidities, diagnosis that are critical to their ongoing improvement and success. They're bringing our attention to problem areas that could indeed land these patients back into the hospital and cost Medicare a lot more money. Nobody wants to go to the hospital. We want to keep these patients healthy and moving forward. So our attention through PDPM is being drawn to potential problem areas that we need to identify and address. So that ARD selection date is critical for many reasons. We want to capture what it is this patient is presenting with, and we need to look at that hospital situation, talk a lot more about that. We need to make sure we understand the clinical review piece that is critical to the success of our patient. So those items that are highlighted as we go into PDPM in more depth are critical. The usual performance for GG, we know that GG, usual performance, especially on rehabilitation patients, that is how CMS is judging our performance. What is the patient admitting to us? What is their baseline that they are presenting to us with in their self-care and performance compared to the discharge usual performance? That is a critical picture, a snapshot that is being publicly displayed and used to determine our success as a skilled nursing entity, our facility. So it impacts our QRPs, and it certainly impacts our reimbursement in PT, OT, and nursing, and will be audited and is being audited. So we'll have some more talking points on GG usual performance. We've got to make sure it's usual and documented, and the findings are there in the medical record of our usual performance determination. Then we've got our interviews that have to be done in that 7-day window. We know GG is first 3 days usual performance before the benefit of intervention. Interviews cognition, the BEMS, depression, the PHQ-9 are required in that 7-day window. Anyone can be trained to do that. Whoever is doing it needs to be trained, needs to have competency checks, because those are significant also drivers of critical patient care as well as reimbursement. And then we have our optional IPA checks. If something arises and you're expending that effort, the resources to care for those changes, we need to cost that out and see if an IPA should be taken as well. Then you've got your month-end triple check and auditing of your PDPM capture. That needs to be, these are all steps that lead to optimal success for clinical and operational outcomes. So let's keep going and see what we've got next. Many of you, if you know me, have seen this, because this is my cheat sheet that I have with me every time I talk about PDPM. And every day it is with me at my side. So I'm going to let Ken pull this up into the actual document. It is our cheat sheet. We call it our QRM PDPM buzz sheet because a honeybee is our little mascot. So that's where the buzz comes from. So what this was really designed to do was to create a workflow document. I'm sure you probably have something similar. Whatever works for you in your setting, use it. It's just that this, for us, listed all of the items that drive your successful PDPM capture, and also is pointing us specifically what we need to be looking at for that patient. So first off, day 2, if I could have my dream come true, we would be looking at, here comes this patient. When's our assessment reference date going to be? Based on what are we finding in the hospital for IV nutritional fluids, nutrition and fluids. What can we capture it? What day was that administered? Can we capture that in the 7-day look back period? And if so, let's select an ARD date appropriate to that and make sure the entire team knows the assessment reference date, so everyone can get the information into the documentation so that the MDS coordinator can grab it by that ARD date to capture the right level, right? The right PDPM HIPS codes. Very important. The other thing that's important right out of the gate, what's the primary reason for the SNF stay? What clinical category are they going to fall into? Do they have surgery? Who's going to be skilling this person? If it's going to be, if the skilling entity is going to be nursing, then nursing needs to know that, right? The documentation's got to be stellar. If that patient doesn't have any clinical priorities, then, or urgent needs that fall into those top nursing categories, then therapy is going to have to be the skilling entity, and we'll have to deliver 5 out of the 7 days, in the look back window of skilled therapy that needs to, for them to qualify for that Part A stay. So somebody's got to provide that daily skilled intervention. That doesn't go away. That's still there, right? Those are the most important things. What's the ARD date? What are we going to, do we need something in the hospital we're going to capture? Who's skilling the patient? What's going to be the primary reason for the SNF stay? I have to say again, it's not why they went to the hospital. We are now looking for, they didn't go home. They didn't go back to assisted living. They came to our SNF. Why did they have to come to our SNF? What is that diagnosis? That's going to drive your clinical category. So I'm going to scooch down and just go through these categories really quickly, always in this order. This is the order of your HIPS code, right? Which tells Medicare what to pay you. Your PT and OT component has one case mix group for both, but you'll see different rates of pay. Based on your diagnosis, you'll fall into one of these 4 categories. Based on your GG score, you will fall into a case mix group, right? So if you have COVID, for example, you're probably medical management. If your GG score was 10 to 23, which is pretty independent, 24 being most independent, you would be in a TK, case mix group. K would be your HIPS code. It's always the second letter for the PTOT. Let's keep going. I just want to make sure you can orient yourself to this. The speech component is a big deal. And we're going to look at the impact of it in a minute. There's a lot going on here. This is not for speech alone. None of this is for a single discipline. This is for every single clinical eye in the building to be looking for these potential comorbidities. If you have anything on that left-hand column, aphasia, beginning with aphasia, There will need to be documentation in the medical record to support this capture, and that item in I-4300 would need to be checked. On the right-hand side, these diagnosis codes for laryngeal cancer, apraxia, dysphagia, for example, need to be mapped to in your CMS crosswalk, which we'll look at in a second too. That CMS crosswalk is critical because it will tell you whether or not that diagnosis of dysphagia will actually map to a speech comorbidity. If it does not, you will not get credit for that. You might need to query your physician to see if there is a more appropriate optional dysphagia diagnosis code for this patient's condition. If so, get that documentation of that diagnosis from your physician. Make sure it's in the medical record, make sure your documentation is backing it up, and make sure that diagnosis code gets in the MDS in I-8000 and carries over to the claim. Very important. If your I-20B primary reason for the SNF stay is one of these diagnosis codes, you have to have it in both places, I-20B and I-8000, for it to be picked up as a speech comorbidity. That was an aha moment for us in the beginning. Right? And then this number one problem missed area in the United States, I dare say, is Section K, swallowing disorders. Every single person that watches that patient eat or drink or take medications in the assessment window must understand the importance of these questions. Did the patient have a loss of liquid from mouth when eating or drinking? Were they holding food in their mouth after meals? Were they coughing or choking when taking medications or during meals? And was there complaint of swallow or pain, difficulty pain with swallow? Anybody, everybody looking at this patient must know the importance of that. And the reason why, if somebody's coughing or choking, that could be a sign of aspiration. Aspiration can lead to pneumonia. Pneumonia can lead to rehospitalization. We are responsible for keeping these patients healthy and at their highest level of safety and well-being. We need to know these potential problems, document them, and you just one time, if you see this, if it's documented in the medical record and look back period, you can check that box, and if it's documented, and that will qualify this patient for a swallowing disorder. It's not diagnosis driven, right? This one is not diagnosis driven. So when you get to your speech component, you're going to have two columns, two components in your speech case mix group. I'll get there in a minute. So you've got the first column, very much linked to your acute neuro primary reason for your SNF stay, your comorbidities, and cognitive impairment. Anything less than intact on the BIMS, you will check cognitive impairment. The next column is, do they have a mechanically altered diet, or Section K, potential swallowing disorder? Neither, either, or both. If nothing is going on in any of these items, you would be in an SA case mix group. None and neither. SA to SL. All three and both, you're going to have a lot of potential problems that's going to require a lot of care from all of the caregivers in the building, and that would be in an SL. This category, and I'll show you the range of the reimbursement clearly. The amount of care needed for someone without problems, much different than someone that requires, that has all of these problems identified. So speech is a big deal. Let's go to nursing. Let's keep going down here to the nursing component. And there's a lot going on here. I'm just going to orient you to this tool. I'll let you guys take it from there. You're going to start at the top with your extensive service category for nursing. You're going to look at these requirements. If you can say yes, they had one of these items, trach and vent, trach or vent, infection isolation, you say yes. Okay, go to the right. Was their GG score 0 to 14? If you say, whoops, no, my GG score is 15 or 16, you're not going to get in this category. 15 to 16 GG score is on the independent side for nursing. Therapy is a 24. The difference? Therapy includes oral hygiene and walking, and nursing does not in the GG score. So if you say, nope, they were 15 or 16, you go down to special care high. Did you qualify for that? Yes, I did. Maybe you had COPD and shortness of breath while lying flat. Great, you captured that. Now go to the GG. Oh, I had a 15, 16. Well, I can't get in that either. You got to keep going down. Note, please, that in the special care high, the depression criteria kicks in. And that depression criteria is a significant impactor. If somebody is depressed or shows signs and symptoms of depression, they're going to be less interactive, less engaged, less able to benefit from our services. We need to identify it and address it. Don't be afraid to address it. It needs to be taken care of, right? And Medicare will be compensating you appropriately for that. Um, you could go all the way down, special care low, you still have to have 0 to 14. In the special care low, we're going to talk about some things that are typically missed. Just make sure all of your nurses and your physicians know the criteria in each of these categories. Make sure you're paying attention to your GG score. Make sure you're capturing the depression criteria correctly according to what was in the PHQ-9 interview. That's the only thing that impacts that depression criteria, PHQ-9 score. And then when you get to clinically complex, it's still the clinical presentation, and anybody above that had 15 or 16 will default to clinically complex. So in clinically complex, now your GG score can be 0 to 16, and yes or no depression. The two bottom categories, behavior and cognition and reduced physical function, are really not presumptive skilled coverage areas. So if you're finding someone's going to be down in these bottom two categories, you need to look at other skilled services being delivered and required by your patient and make sure you meet the criteria. For your behavior and cognition, these are more independent people, 11 to 16. And now restorative capture comes into play, not depression. Your restorative criteria, you can still be in this if you have 0 to 1 restorative nursing programs, but note your restorative programming has to be delivered for 6 out of the last 7 days for at least 15 minutes each to get you to meet this qualification, right? So reduced physical function, completely restorative, GG, now 0 to 16 on your GG, and restorative. So that's nursing. So again, every one of these category requirements are so important to making sure that your interdisciplinary team and everybody with clinical eyes knows what to look for. Make sure it's brought forward, captured, documented, and if present, if it needs a diagnosis, it's not covered in your diagnosis, someone has to get to the physician to get a diagnosis. We cannot diagnose without nurse practitioner, physician, depending on your state. You've got to have that. And it has to be in the last 60 days and it has to be in active condition for you to claim it. It has to be in the medical record. So make sure you're in that 7-day window looking hard. Okay, let's go to the last but not least is the non-therapy ancillary component and checklist. This is broken up a little bit so that for easier finding. This is a system in which you get more points for the more critical, complex conditions. Every one of these 50 items has points assigned. The more clinically complex, the higher the points. So you've got your IV feeding, high, low, and then the active diagnosis are in alphabetical order to help you find them. And when you get all the way, when you see to the right in red, you'll see where on the MDS these items need to be captured. If it says I-8000, you have to make sure the ICD-10 code that you're using is actually going to map in CMS's mapping tool to the NTA component. So that's very important that all of those steps are done and complete, and there is somebody championing this NTA list. It doesn't just happen by accident. I just have to say the successful team members have assigned a champion of this non-therapy ancillary component and checklist, as well as some of the other diagnoses, like for the speech comorbidity and the primary reason for the SNP stay. Strong clinical eyes, very important. And I'll talk about some some misses that we're seeing, heavy in the malnutrition and morbid obesity. We're seeing more and more of that coming through. When you scroll to the bottom of this, you will see the range for your case mix category, your case mix group. If you have 0 points, it's an NF. Your HIPS code would be an F. 1 to 2 points is the range, 3 to 5, 6 to 8, 9 to 11, 12 or more. If you're on the bubble, if you're on a 2 point, look again, just make sure this is significant to your building. We need to make sure we know all of these problems. They're all very critical for patient care. And for that, you're going to be paid triple this dollar amount for this component day 1, day 2, and day 3. It is absolutely critical that we identify uh, these clinical needs. Okay, I'm done with this tool. You will have a copy of it, and I hope it helps you. If you have any questions or feedback, we love it. So keep it coming. So Ken, I'll let you go back to the presentation, and we'll keep on moving on. Okay, Ken, I'm hoping you can get me back to my presentation.
Okay, 1 second. My display window went away. So let me get us back to the right slide. Okay.
Don't worry, I understand completely. That's why you're driving, not me.
Okay, there we go.
That's great. Thank you. I'm still seeing the tool. I'm going to just talk while he pulls it up. The next slide, I believe, is talking about some of these trends and how important our razor sharp, and we're retooling here, right? So our razor sharp insights are key. If we miss an active diagnosis due to the lack of physician query, or we're not, looking up that RAI instruction manual to make sure this is a qualifier, or we're not checking that ICD-10 mapping tool, we're going to run into the wrong category capture. Your diagnosis will impact, of course, your PTOT category, which is driven by that primary reason why people came to us in I-20B. If we miss those diagnoses, we will miss speech comorbidities that have to be captured and mapped to that ST comorbidity and captured and listed in I-8000. Even if it was in I-20B, it's got to be in I-8000. I can't say that enough. If we don't have those active diagnoses identified in the documentation within the last 60 days by the physician and actively noted in the documentation, we're not going to get that. We're not going to capture it. And you're given the care. So this is why I'm so urgent about this. And you will miss your NTA points. And that is a huge cost we cannot miss. I already mentioned the common misses: malnutrition, morbid obesity. Your physician being tuned into that is critical. How many times are our patients coming directly to us from the hospital or from a decline condition where what was their diet? What was their intake? Oftentimes they're very much in an at-risk situation for malnutrition. Your dietitian cannot document that and qualify us. It has to be a physician. So make sure that we're good on that. Required documentation not present in the medical record will cost you those component captures. You have to have documentation there. And the location of where in the MDS these items are found is also critical for you being able to get credit for it. Oftentimes we're checking the box instead of listing it in I-8000, but it requires the checkbox. So we've got to make sure we understand how the system works. So I'm going to keep going on this trend and talk about lack of use of the CMS mapping tool. I think that most of the software now will trigger you and will have it built in, but just in case, you want to have it readily accessible. We've included the link here. When you go to that link, it will take you to cms.gov. If you scroll to the bottom of that page, it will take you to the PTOT, the SLP, and the NTA mapping folder files. At the bottom, there's those tabs. And you can just go in and click on, your diagnosis or your comorbidity if you have aphasia, and you can see all the diagnosis codes that would qualify for that. So if you're struggling or if your physician is struggling, share that with them, please. We need everybody to make sure that you're getting credit. So making sure you have the right diagnosis for the condition that you're seeing is critical for all the above, right? PTOTs, SLP, NTA. The other thing is you want to capture it and have it taken away. Right? We want you to keep every single penny. So let's keep going and see what else we've got here. We're talking about, again, what are the best practices? What's the right angle? Every single location is different. You all are unique. You all have different ways of communicating and collaborating. Whatever works for you, whether it's a daily meeting, twice a week. I would caution that once a week is not going to let you get your attention timely enough to address things within the 7-day window always. So daily, if there is the opportunity to have a quick discussion, in depth, reviewing that buzz worksheet until you guys feel confident that you know everything that you need to be looking at, I strongly recommend that. You've got to make sure that you're capturing everything. So on your new admission, ideal, day 2, right? They come in at the night before, you have a conversation the next morning. What's the ARD date? Get the information out of the hospital. Before COVID, we had so many locations that had the pre-admission tool handy that we had created or that they had created. They were gathering information pre-admission that would tell them pretty quickly what PDPM category they were going to capture. That there's a lot of answers in that hospital and from the family. So all of the pre-admission information you have, bring it to the table to your team. What's the primary reason for the SNF stay? Have a discussion. And who is the skilling discipline? Lock it down so everybody, all the documentation's there. And then by day 4, you've got to make sure you've got that GG completely captured from the minute they get there, midnight 1, midnight 2, up to 11:59 p.m., midnight 3. You've got to be there to get that GG IDT documentation entry into the medical record of usual performance. It has to be there. I'm not going to name names, but managed care companies are looking right now and questioning that GG, and it will be audited. We know that. It is the driver of PTOT and your nursing reimbursement in a big way. And day 4, make sure you got that GG documentation entry into the medical record. Review your PDPM HIPS capture so you know if you have anything left that you have to go get. Because once that ARD passes, it's too late. So identify what's missing in your documentation. Identify what diagnosis you need to go back to the doctor with. Do not leave it on the table. Get it every penny. Make sure you know your people so we can care for them in every way. Utilize your tools and your cheat sheets. And I've got a toolkit for you next that we're going to share a few tools with you, a few additional tools. Poor Ken, I'm making him bounce all over the place. But, in your toolbox, you've got to have that education as the ground floor, right? You've got to have everybody on the same page with understanding this model, communicating what is critical to success. Trend your outcomes, right? What are we doing? What are we capturing really? And then audit to make sure you're going to really keep what you're putting on that MDS and that you're getting credit for everything you're delivering. So we've got the buzz sheet. We've already looked at that. We've got a Section K crosswalk. The Section K crosswalk, what we're finding is that a lot of the swallowing problems in Section K are in the speech documentation, which you absolutely can use. Here's an example: speech language. You've got retention, you've got residuals, you've got residue. What does it mean? Food is left in the mouth after your meal. Where to code it? K0100B, holding food in mouth, cheeks, or residual food in mouth after meals. So here's your speech documentation and what it means and where to code it. I think it's, you're going to have this tool. Feel free to use it, make it your own. But, your speech therapists speak a different language. I'm just saying, I'm a PT, just saying. So we're finding it all day long in Section K information in speech. So let's go to the next tool. Just for sake of time, I'm going to just kind of go a little bit faster through these tools. This is an NTA component capture organized differently. This one shows you where in the MDS to capture it. You got section I going there at the top left corner. Then you've got your NTAs in section H, K, M, O. You got all these different things. And then you've got the items that have to be listed in I-8000. So that's very important, again, that those diagnoses that identify that are going to map to the NTA component. Don't forget that critical piece of mapping that diagnosis. It's got to be a mapper. All right, we're going to go to the next tool. Poor Kim, I'm working him to death here. Here is something that we have sent out in the past. We partner with Data IQ. They're a business intelligence partner of ours. They have built this for us, and you can use this for every building in the United States. I believe this building is in Hawaii, so if you're listening in, we're jealous. But it is the address of the building. All the buildings are in here. You put your HIPS code in. You can put in your start date. You can put in your length of stay, and you will get a total revenue and average daily rate. And this includes your average wage index information. You can plug in your VBP multiplier as well. And you can see now what your reimbursement is going to be. If you go to the, I'm sorry, can go back to the left a little bit. I'm so sorry, where are you out here? So PT and OT, those first two columns, PT, OT, if you notice PT's rate is 126.54, OT's is 117.75. If you go down to day 20, you will see that on day 21, the rate drops. It drops 2% every 7 days going forward. But that 2% drop, we're talking about a difference of 126 and 124 from PT and 117 to 115. So it's not, you're not going to discharge somebody for this, right? I'm going to go back up to the top, and I'm also going to show you your NTA. If you go over to your NTA component, it's column I. Whoop. Yes, it is. So this is where day 1, do you see 366.17? Day 1, day 2, day 3, but day 4, it's not multiplied times 3 any longer. Now it's 122. So this is why it's so important that we spend the time, the focused attention, we dedicate someone to owning the NTA component. This is a significant impact to the success of your building, right? I'm going to go to another tab here, if you don't mind, Ken, if you could go to the CMI tab. If you click on the CMI tab, what you're going to see is the PDPM group. You know, this is your HIPS code, A through Y. So by component, you're going to be able to see the PT rates for each of those HIPS codes. And you can see the multiplier is the case mix index. You got your base rate times your case mix index and your rate. So your rates for PT and OT range from like 62 to, lower 90s, 80s. Your speech, on the other hand, let's look at that. That speech ranges from $15.75, nothing captured, down to $97.50 for this building. $15.75 to $97. The difference from the $15 at the very top to the $42 can be captured with swallowing alone. That section K question. No diagnosis required. It just takes our skilled, it doesn't even take skilled, it just takes observation by your medication nurse, your CNAs, anybody watching that patient swallow, everybody watching that patient swallow. The difference from $15 to $42 a day. That is huge. I'm going to look at the nursing component, and I'm just going to show you in column K. Column K, I'm going to point out the HDE2, which is special care high. You've got your 0 to 5 dependency on your GG score, and the 2 at the end means you've captured depression on your PHQ-9. Your daily rate on that for nursing is $259. The same patient that did not pick up depression will be HDE1. That is a difference from $259 to $215 a day. That is the impact of your PHQ-9. Make sure you're doing it correctly. Make sure it's getting captured. I'm just going to stop with that example, and then you've got your NTA, 0 points. Let me start at the top. Your A, which is your highest, 12 or more points, 264 a day, and that's going to be multiplied times 3. Day 1, day 2, day 3. Or nothing captured, $58.75 a day times 3. We're talking hundreds of dollars a day difference now. So this is a powerful tool to help reinforce the importance of focusing in on our patient needs, documenting it, capturing it, engaging your physician, and then making sure we're addressing these patients' needs, and you will be paid for it, right? So I'm going to get out of here, go into the next. I think I'm just going to talk through now the rest of these. We put a link in there for GG. This is CMS's training video. It's YouTube video, and it has question and answer. I love this GG video link from CMS. It is fantastic. I use it to train CNAs, therapists, anybody and everybody. We've also included the RAI manual, because if it's not in the RAI manual, we're not going to get credit for it, right? We have to follow the rules in the rule book, which is the RAI manual. And then you've got your ICD-10 coding link again here. You have to know it, you have to use it, have it readily available so that you can get the right diagnosis for your patient's condition. So there's your toolkit. Feel free to use those. I'm ready to go on to the next slide. All right, these are some missed opportunity areas. I probably have already addressed them, but really it was so hard to drill this down. SLP, I looked back at some of my prior trainings. It's not getting, it's still present. We've got to change our approach on capturing these ideas, these areas for swallowing. We're going to go into nursing, NTA, that optional IPA, and the ARD selection, and just share some things we're finding real quick. So I'm going to go to the next slide. I've talked about this over and over again. SLP, swallowing, biggest opportunity. Oftentimes we're seeing that SLP has made diet recommendations, but it's not picked up in the orders. So it's not being picked up on the MDS. Swallowing disorder prompts, everybody's best practice of like, let's build a prompt, let's build a UDA, let's build it so people look at this to bring attention to it, but it's left blank. These are those 4 questions again. Make sure everybody knows them, talks about it, brings it to somebody. Let's get it. And then ensuring comorbidity, active diagnosis, and conditions are captured in the right MDS location. We talked about that, right? So the next slide is really going next into the nursing category. COPD with shortness of breath while lying flat, number 2 behind swallowing. Seriously. And as we're looking at these post-COVID patients or active COVID patients, respiratory failure and oxygen therapy has been missed. We see it being missed. It's present in a lot of our cases. Again, and then hemiplegia, hemiparesis. We've got to observe for the presence of it. It might be not listed as a diagnosis, but they're still showing hemiplegia, hemiparesis. It's an active condition impeding their ability to improve. Let's query the physician for clarification for neuroresidents. Let's get it identified. Next, we've got the NTA. I don't think I can talk about this enough. Engage your physician. Make sure they understand how this works. Show them the crosswalk. Engage them. If there's an unclear active diagnosis, get it clarified. Make sure it's all captured in the MDS in the right section, and it makes it to the the claim. Review your IV meds. Resolve your inactive diagnosis following physician confirmation. Oftentimes, we're also seeing that patients are leaving the hospital, they've had pneumonia, they come to you, they're still actively, going through the issues of pneumonia, but that order or that diagnosis got resolved before they came to you. It's still active. Get your physician involved and get it activated. Let's go to the next slide. The optional interim payment assessment. Especially now that we're taking patients that have had COVID, we're facing the aftermath and some of these long haul problem areas. We need to look for these things. And if speech comes in after the ARD, often they're identifying swallowing disorders. You've seen the impact. It might need to be an IPA assessment. Always use the PDPM calculator before you take an IPA. IPAs are not mandatory. They are completely optional. You do not take an IPA just because someone, came off their IV or someone, came off their mechanically altered diet. That's not a requirement. And then, of course, if they become isolated, you would want to look at an IPA if you start IV feedings, if you've got oxygen therapy while a resident. Look at those things. Those are very high dollar items. Let's look at the next one. With your ARD selection, I believe we've hounded that down with the hospital information, providing information that we might need to capture in our look back window. So if you've got nutrition, hydration IV in the hospital, and you could set an ARD date, so in a 7-day look back, you could capture it, be careful, be mindful, and do that, right? Always involve your speech therapist prior to the ARD if there's any potential indication for speech therapy so that we could capture all those items. Remember, speech therapy is not required to complete Section K. Not required. It's everybody's clinical eyes. Ensure completion of the required interviews, your BIMS and your PHQ-9. And if you've got respiratory therapy, you've got, trained nurses all over everywhere are providing nebulizer treatments, respiratory treatment. It needs to be on 7 days. So when you're selecting your ARD, take that into consideration. Okay, what do we got next? Watch for these COVID residuals. It's been in the news more and more frequently. Neuro symptoms, pneumonia, coronary artery disease and stroke, cognitive deficits, oxygen use, dehydration and malnutrition, painful swallow. Who that had COVID did not have pain when they were swallowing? That was like the number one sign and symptom in the beginning. So these are real problem areas that will drive PDPM. So let's make sure we're looking out for this. And if you need to do an IPA, do an IPA. But cost it out first. Okay, let's look at what we have next. All right, pulling it together, Hopefully we've given you some tools that will help you. This just is an example of how the model works. You've got your base rate for each one of your components multiplied times that case mix index. The higher the case mix index, the more complex, the more Medicare will pay you. We've talked about the variable per diem, day 1 through 20 for PTOT, then it drops 2% every 7 days. We talked about the NTA multiplier for the first 3 days. Then when you look at that payment range, I bring your attention to that NTA component, the nursing component. Those are wild swings. Speech component, wild swings. So at the bottom at the end of the day, your reimbursement can be $372 or over $1,000 a day. And you all have a big job to do with very little reimbursement. So any penny that we can get you, we want to get it. You deserve it. So I think that when the team pulls together and looks at this and the impact our clinical skills can make to the bottom line and the success of your organization, it becomes incredibly powerful. We love working together with teams and looking at the financial impact of your clinical eyes and care. So if we keep going to the next tool, how are you measuring up? People ask every day, I don't know, what's normal? What are people capturing? CMS has data available. Core Analytics, we work with them closely. They have created a SALT report, which is their answer to the Pepper report for now, which shows you in real time how your capture is trending towards the national percentage. This national percentage, I believe, is from the third quarter now of 2020. So if you can pull up your building's capture, you can compare yourself. Your depression in split, for example. Right now, CMS around 15.3% is what we're looking at, the national percent average. NTA points, 12 or more points, 1.5%. Average daily rate, $5.99. You can start comparing yourself to this and looking to see maybe if you've outperformed it, fantastic. If you are an outlier, you always want to make sure your documentation is there. If you're an outlier on the low end, you might be leaving money on the table. But this is just something to give you something to gauge how you're doing. All right, let's look at the next slide. Empower your team. Now is the time, right? You want to be the best of the best. Everyone's gunning for those 5 stars, best possible patient care. We've got to know our patients to meet their needs. Your clinicians, your team members deserve this education, right? To know what they can do to help. What can they do to really focus on? So find out what you need, implement training options, use all of your resources, use all of your software, use all of your partners, provide competency checks, delegate responsibilities amongst your team members to capture everything, use your data analytic tools, and track and trend results. So what have we got next? A little poll. So Ken, I'll let you pull that poll up again. So what additional PDPM resources do you need most? I'm curious, I think we're all curious. You need more GG tools. That's been very difficult. We couldn't get G figured out for years, and now we got GG, totally different, opposite. General PDPM training. Do you need operationalizing systems, communication? Do you need more help, like, using all these tools and really making it come together as a team? Do you need more auditing and analytics? Not really sure. Let us know what you need. We're all here to help.
Okay, we'll leave this poll open for just a few more seconds. If you would just click on your screen, select one of the categories, and we'll give you a few more seconds, and then we'll share those results. We do have several hundred folks on the line today, and appreciate all your feedback. This will be interesting for all of us to learn, I think. Okay, I'm going to go ahead and end this poll, and we'll take a look at the results, Susan.
GG, I knew it. It is so hard. It is really, really hard because we need to get that from the caregivers, not therapy. Therapy alone is not your usual performance. We don't watch that patient eat, drink, toilet, move every single minute, 24/7. It needs to be before the benefit of intervention. One time snapshot of a transfer, or 2 times, or 1 meal does not make usual. and it's got to be collaborative and it's got to be documented. So I'm going to continue on that GG mission. Operationalizing, I do agree. I think that is so hard to really come together with the time that it would take to actually figure this all out before that 7-day ARD date. So I'm on a mission to identify what works best. And then those auditing and analytics to show you where you're at, I think is incredibly powerful. So there are many, many organizations out there. We have an analytics software partner that we utilize. It's critical for all of us to know where we're at. It's just so important. So thank you for that feedback. We're all here to help you. Reach out to all of us. And then I think, Ken, in follow up, I'll turn it over to you for your simple review.
Yeah, and just very briefly, we're going to bring Melina Helikius with Simple in to talk about some of the PDPM connections we have between some of the content you're learning today and some of the software available.
Yeah, thanks, Ken, for the introduction. So Simple LTC offers a complete MDS analytics package for improving clinical outcomes and maximizing reimbursement. Our MDS analytics suite includes a variety of PDPM tools. So we have a pre-transmission scrubber. We also have a PDPM Diagnosis Explorer tool, which we have a free version of that available on our website. We have a revenue forecast report and so much more. If you would like to see the system in action, we actually have a group demo later today. It's in an hour at 1 p.m. Central, and you can register for that by clicking the link, that sign up for a live demo button in your handouts. We'll also post that link in the chat section as well. Alternatively, if you would like a personalized demo, we have a poll question coming up here that asks, would you like a personalized demo of Simple LTC's MDS analytics solution? If you mark yes, you will be contacted by a Simple LTC sales rep, and we will reach out to schedule a one-on-one meeting with you. So if you could just answer that.
Okay. Thanks, Melina. And we'll leave this up just for a few more seconds to let us know if you're interested, and then Melina can follow up with you, or you can click that link in the chat that I think Jessica has posted, so you can join the live demo in an hour or so. But Susan, why don't we go ahead and move into Q&A? And also Amy with QRM is with us today, and she's been collecting those questions. I know we've got some great ones. And I know, by the way, we're running a little bit long today, but these questions are worth it. So stick with us. So Amy, what's our first question?
Yes, okay. Can you complete the functional ability section by day 3 instead of day 4?
Oh, sure. Yes, absolutely. What we want to make sure is that you've gathered all of that information, you've actually gathered it from your caregivers, and that you have done so before the benefit of intervention. So if the patient starts making progress in their walking, for instance, once they start benefiting, then stop assessing the walking. It might be day 1 or 2. So you stop that individual GG item at the point where they have now started showing the benefit from intervention. So yes, but what we want to make sure is that you've got that documentation entry that's an interdisciplinary collaborative decision on the usual performance in a note in the medical record for reference by auditors. I hope that helps.
ARD chosen earlier than 5-day therapy to capture IVF and acute. Will it affect assessment because RAI indicates skilled needs to have at least 5 days therapy?
I think that the main thing is that it's every day, right? Daily skilled intervention is the criteria. So if you've got 5 days or 3 days, you've got 3 days. It's daily. If you've got it every single day, you need to watch for that though, and make sure that you've got the orders for the 5 days out of 7 for the therapy, you've got nursing, but just, be mindful of that. And just make sure it's daily skilled intervention being delivered. I hope I answered that question.
Great, thank you. Is documentation by dietary for risk of malnutrition or malnourished sufficient to take I-5600, or does this need to be written by an MD or nurse practitioner?
An MD or nurse practitioner. And that was a question in ANAC chat. And I just saw that question. So that's how Carol Mayer answered it. So I'm going to stick with that.
Okay.
Definitely we need that physician.
Can nursing just answer self-care questions, therapy answer function, and therapy complete the mobility section? Nurses, do not answer to the steps or card transfers.
There's no rule about who is required to answer these questions. Just to be clear, it is the caregivers that, we need to assess each of those items. That is what CMS is expecting of us. Someone's got to do it, and it needs to be usual. So if you assign therapy to oral hygiene, for example, and they just do a mock-up of oral hygiene one time, how many times has oral hygiene been performed with that patient? So what we need to do is look at who is the one that sees this performance the most to help us truly gather usual performance. So I think it's collaborative, it's interdisciplinary, but you also are charged with identifying usual performance. So be careful who's answering the question and whether or not it is a true representation of usual. Hope that helps.
What is the best way to have GG information accumulated? We are having nurses do a UDA for GG twice a shift in a 3-day window. Then IDT team enters narrative notes at PDPM meeting at day 5. Several UDA forms are completed with wrong information.
Well, that's usual. I mean, that's a great approach. I love that approach. The more frequently throughout the course of the day, we can gather information from the caregivers, the better. And then having that interdisciplinary meeting with a note entered into the medical record to solidify the interdisciplinary decision of usual performance is key. Just like with G, we've got people entering into the kiosks every day, all day long, that are entering misinformation, and we know that. It's been a challenge in this industry forever to get this right from the caregiver. So, it's an assessment. We need nursing engagement. We need, therapy engagement. It's just, really important that we go back to the RAI manual. I would challenge everyone to watch those GG CMS tutorial, that the link that we provided you here. Those videos are so impactful and the questions are clear. It really does put things in perspective, but I applaud you for your effort at your gathering frequently the information that you need.
I've heard that GG function scores dropped significantly when the pandemic started. Is this improving?
It is improving, actually. We just saw some graphs from actually Simple LTC for another presentation that we're working on, and it did show that the scores for self-care and mobility were so the progress wasn't as high. The outcomes were not as great, and then all of a sudden this last month you could see the bar graph just start going up on the outcomes. So definitely COVID impacted our outcomes in a serious manner, and we're starting to see improvement. It's exciting.
Are you seeing a lot of telehealth services provided during to reduce touch points and exposure risks?
100%.
Yes.
So, we're involved with all in-house, therapy programs at the moment. That's all we do. But, being able to strategize with your therapy partner and your therapist on how to eliminate exposure as best possible while meeting the needs of the patient really did bring on in a big way the option of remote, which is where you're on site but not in the room with the patient. So you would have another caregiver in the room helping, but you're on site, so it's remote. We used that a lot to limit exposure to active halls and decrease exposure, amongst the facility. And then yes, we have used telehealth. It's still available to us, and when needed, it is an incredibly powerful option to us to be able to reach the patients that otherwise would be suffering from lack of mobility and intervention. So yeah, it's been fantastic, and would love to see it stay as an option.
Does QRM come to facilities to sit in on IDT meetings or help do hands-on training?
Absolutely. Absolutely. We have a clinical reimbursement support option with our program. We believe it's an interdisciplinary approach. So our rehab management program is not isolated to just therapy. We are all in and strongly available. I'll just say that we're excited about seeing teams come together to accomplish this. So yeah, we're available.
Okay.
Thank you. Yeah. So Ken?
Okay, awesome. Well, Susan, before we close it out, do you want to give people a little bit more information on how they can get in touch with you?
Oh, thank you, Ken. So as I mentioned, we are in-house rehab. We very much want it to be done right. That's our whole focus, is success for you and your patients. We want to be at the right cost. We want to help get the right people with our recruitment teams. And we want you to get reimbursed for what you're doing. And we want you to keep it with the medical review support that we provide. And all of that leads to incredible results. And you all are amazing at what you do. And we want to support you every day. And thank you. We've got our contact information, info@qrmhealth.com. And we've given you other ways to connect with us on LinkedIn and Facebook and Twitter. And we just appreciate this opportunity to be in your life right now at this moment. So best wishes to all of you.
Well, I want to thank Susan Kroll with QRM for being our subject matter expert today. Really enjoyed the information. That's a lot of very helpful details, Susan. And also thanks to Amy for helping out with the Q&A section today, Amy from QRM. So just so you know, we have recorded today's session. We will place the recording and the handouts on the Simple LTC website. We'll have that up a little bit later today. You'll also get an email about that tomorrow with the link. So I want to thank all of our attendees. We really value you as partners in the industry, partners through PDPM and all the change that we're facing right now, COVID and everything else, and the customers of Simple LTC who've joined us today. Thank you so much for joining us, and we hope everyone has a great day. Thanks so much.
Thank you.